Welcome to
Recording in progress.
okay, so I'll get rid of that. Welcome to this. So I guess I should start by just saying that I'm no expert here. I'm not formally trained in transgender medicine or whatever. It's something that I've been doing for the last 6 or 7 years since I joined Victorian AIDS Council, which I joined so that I could use my HIV S100 prescribing certificate, not specifically this but in Victorian AIDS Council, now Thorn Harbour Health, there's a lot of transgender medicine, so it's kind of something that is part of the package. And so I sort of learned as I went along, and I guess the people around me didn't feel they knew any more than I did. So it's definitely a learn as you do. So now I was hoping that would take me to the next. So, all right, by the way, please feel to interrupt. This is a kind of overview, and I don't know if we'll get through all of this, or if we get bored, we'll stop. But please just ask anything you like, just speak up. I can't actually see you at the moment, so just speak up if you want to ask anything. So I think that people will approach us to ask about hormones, or perhaps to ask about referrals for other therapy like surgery. But I think the first thing that I point out to people is that transgender is a lot of aspects, and it's not just taking hormones, and it's not just having an operation, although for certain people it might be. But people can transition through totally social means or through totally legal means, like name changes and things like that. And not everybody takes hormones, and certainly not everybody by any means has any form of surgical operation. And then, of course, we need to get away from this whole binary concept, and transition is not necessarily from the gender assigned at birth to the other gender. It is any range of partial transition, gender fluidity, not being any particular gender, or frequent changing, or just being non-binary. And it is a whole lot of new words and new concepts. And yes, we currently talk about gender dysphoria, and that's the official diagnosis, and the DSM-5, the Diagnostic and Statistical Manual 5, the sort of list of official psychiatric diagnoses, lists gender dysphoria as a diagnosis. But that's going to be changed when the next edition eventually comes out, and we're going to talk about gender incongruence, because that's supposed to sound like less of a disease or a condition, and just more like something that people can have. And some of the kind of medical people have been worried about that, because if it's no longer a psychiatric diagnosis, then maybe there won't be insurance money to pay for operations or to pay for mental health support. If it's not a disease, then it doesn't need to be paid for. So anyway, we'll see how that goes. But the term gender dysphoria is likely to officially disappear in a few years' time. We did, obviously pronouns are a very current issue. And I think that what are your pronouns is a very good first statement if you think that it is a problem or is a concern for the person in front of you. And typically, yes, he, him, and his, and she, her, and hers, and they, them, and theirs are typical combinations which even best practice now allows us to use. I think that I try and use they, them, and their as often as possible, because it's fairly broad. Some people will be upset that you didn't specify that their pronouns are specific, such as he, him, his, or she, her, hers, but I guess we just have to do our best in that regards. Preferred names, obviously we can now enter that into best practice, although best practice still doesn't use preferred names preferentially, but what is your name, and where the name given at birth is not the name that the person currently uses, it's nice, I guess, to address them by the preferred name. And just sort of legal name change, of course, people can change their name legally without, they can do that on their own.
Can I just ask something?
Yes.
Someone's in the waiting room called Elijah. Does anyone know who that is? Could it be possibly Guada?
It could, I suppose. Guada was planning to join.
Okay. No, I don't. Sorry, Nick. You keep going. I'll just see if I can work out how I can actually
let them in. Yes.
I just didn't want to let in someone who I had no idea who they actually were.
Yes.
Anyway, keep going.
Okay.
They've disappeared now, so I don't know what's going on there. I'll just mute myself.
So obviously, if people wish to change their name, yes, there's no restrictions on doing that. It's just a legal procedure, and there's no law that says a certain name has to be applied to a certain gender. So somebody who was assigned male gender at birth and wants to be called by a name that people might consider female, there's nothing in the law to stop that. The change of sex on the birth certificate has been a very complicated process. Very recently, Victoria lifted a lot of restrictions on that. And so for most states, if somebody is assigned a certain gender at birth and then wishes to have that changed on their birth certificate, they've actually had to undergo gender reassignment surgery, and that has to be like a pelvic surgery. So at the very least, sort of for assigned males, it would have to be an orchidectomy or a neovagina creation or a phalloplasty. So that's, of course, very few people who really undergo that. So very recently, Victoria has actually changed their rules. And so for people who were born in Victoria, change of gender on the birth certificate is now possible. And for people who were born outside of Victoria, but who live in Victoria, there is a process for changing their birth gender as applied to Victoria. And you can just go online and Google search for something like Victoria gender change, and you'll see the various certificates, and you could theoretically be asked to help someone with that. Medicare, you can change your gender without question, and somebody who wants to change the gender on the passport, there's a form called a B14, which is actually a one-page form, and it just asks you as the doctor to state that you treat this person and that you understand that they identify as a certain gender and that they live as a certain gender and that you agree that that's their gender. So of course, none of you ever have to do any of those things, but in the event that you did decide to, these things are all now very simple to do, and Victoria is the most progressive of the states in this regard, and Queensland is the least. Yes, okay, we did mention pronouns, and she, her, hers, and he, him, his are the sort of specific ones, they, them, theirs, for people who are non-binary, or if you just sort of want to play safe and you're not quite sure what to say. And these two abbreviations, assigned male at birth and assigned female at birth, it's kind of expressions that we might use so that we don't get confused, because sometimes when people are non-binary, you're really not quite sure in your own mind which gender they had assigned at birth, and there's a few reasons why that might be important to you. Obviously, you can talk about trans man and trans woman. That refers to the gender that they arrive at. So the trans man is the person who was assigned female at birth but is now on masculinizing therapy and so on. Non-binary, I guess it's just to get away from the idea that everybody has to be male or female. Gender fluid is the person who doesn't sort of stay in the same place as far as gender is concerned. And the person with I guess I'm not really feel that this is very useful, but you can talk about a person with a vagina, a person with a penis, a person with a uterus, a person who menstruates, all of these terminologies that do appear from time to time, and your patients may occasionally use them or think they are appropriate.
Could I ask a question?
So, yes, please.
So when you say gender fluid, and I apologize if this is a very silly question, but does that mean someone doesn't stay the same gender in their lifetime, or does it mean they don't stay the same gender in any particular time frame, or does it really not matter?
It really doesn't matter, but I would be more referring to I mean, gender fluidity is a global term that refers to the fact that people don't have to stay in the same gender. So yes, you might say that anybody who transitions is gender fluid. And then I would say, so I think that that's what the term really refers to.
So it doesn't mean going back and forth between different
Not necessarily,
genders.
although there are people who openly declare that they simply do not wish to be identified as being of a particular gender. And so they may constantly change how they present and in terms of clothing or whatever they use to declare their gender. So that's, you know, another interpretation. But no, I personally think that gender fluidity is the fact that, or the concept that people don't have to stay the gender that they were assigned at birth. I think that's the most common use of that term. So yeah, so in other words, a global term that covers this whole situation. So when people sort of transition, and you once again, it's really a question of asking what the person plans and wants, because people who are trans either are saying, well, I'm male and I might have been called female at birth, but I'm male and everybody should know that. And that's of course also very binary. It says there's two genders and I was born one, but actually I'm the other. Other people don't consider that that applies to them. And you really are dealing with different concepts here. So I guess step one is don't assume anything, and carefully ask how the person sees themselves, because you will get a range of answers, and what the last person said and what this person says may be very different. But for the person who comes in, I mean, certainly if people come to see me at Equinox and they know that in Equinox we prescribe hormones, and I think that my first couple of questions are around what the person actually wants. And often if I ask that question the wrong way, then I'll get an answer along the sort of physical changes, and people will say, well, I'll get body fat redistribution and I'll get skin changes and I'll get whatever it is. And that's what, of course, the textbook says, or the article that they just read says. And I guess those things are important, but what I really want to know is what they actually want, and not why. I'm very careful not to ask why, because why sort of suggests that people are trying to transition because of some reason, and not because of I've always felt this way, or I've known since I was whatever age that the gender I was assigned was incorrect. And I mean, what do they know? Because some people arrive and they're very well researched down to exactly what they want prescribed, and other people are very poorly researched and they are unhappy where they are, but they actually don't know much, and they're quite sort of unrealistic about what kind of medical interventions and hormones and so on will achieve. And there's a large amount of education to take place in that person. I think that if I start hormones, I'm very much more comfortable to prescribe in people who already know other people who are transitioning or on hormones, and whether that's a face-to-face sort of acquaintance or it's through the internet or whatever, it doesn't really matter. But people who are quite insular and have not any kind of first-hand experience with other people who are transitioning, they can have very unrealistic expectations of what can actually be achieved, and think that you go on estrogen and you'll just become feminine, or you'll go on testosterone and that will solve everything. So yes, to sort of stand back and say, well, what do you really think will happen here? And not why are you doing this, because why are you doing this can be very much misinterpreted, but what do you expect, and what do you know, and whom have you met? And online or in person, I don't really mind about that. Lots of people have got online people rather than face-to-face. Have they tried hormones before? I think is a very good question, because many people have, and they don't want to tell you they have. But I like to know, because first of all, it makes the diagnosis if people have gone to the extent of self-sourcing hormones, or borrowing them, or buying them online, or whatever means they had of acquiring hormones. It kind of proves that they then come back to sort of do it properly and have medical management. So you don't really have to diagnose gender dysphoria anymore. They've diagnosed it for themselves. I do speak to people about regret. Properly screened people who undertake hormonal and medical transition, the official rate of people having full regret and wanting to detransition or transition back to their birth assigned gender is said to be 3%. And the reasons are generally, it's very rarely that the diagnosis was wrong if the screening was correct. And finding it too expensive is certainly one reason. For people who had visions of having sort of surgical transition as well, and finding that, you know, $50,000 or $100,000 was beyond what they could raise. But lack of close support and people who support, you know, people around the family who are on their side, or the close friends or the partner or the whoever it is. So the person who has no one around them to really support, I guess I openly say, well, I'm worried about you because going on hormones is going to be actually tough, and things are going to happen, and you're going to have bad days, and it's going to be hard to manage without the support of the people around you. And I just tell everybody that I'm more or less legally asked to talk about fertility preservation. And I use this question here because people are quite offended by that question in a way, but I try and ask it in an objective way and say that, look, you know, you are compromising your fertility with this, and, you know, is that an issue for you? And of course, if it's some 18-year-old in front of you who's got actually no idea about what their next 20 years of life is likely to bring them, then it's quite an impossible question for them to answer. But people assigned male at birth who, of course, can relatively easily store semen, it's a realistic thing to ask. And people who are assigned female at birth, well, eggs freezing is, of course, not nearly such an accessible or likely to succeed technology, but I still bring the topic up, and every now and again somebody actually wants this. And well, I'll mention in a moment how I refer people who actually do want to investigate or follow up on fertility preservation. And then just to mention intersex, so a few years ago we talked about LGBTI, and largely the I has fallen off that acronym because the intersex population does not feel, in my speaking once again from what I glean, but even in the people who attend Equinox, the people who consider themselves intersex feel excluded by LGBTI. They feel that they are a special group. And in a way, of course, that's true. And somebody who's intersex looking for hormones is not the same as somebody who's trans and looking for hormones. And of course, somebody who's intersex and has, well, may in fact very justifiably medically warrant hormonal support. And it's often a very complex decision and well beyond a decision that I'd like to make. But people who are intersex have felt very excluded over the years, and obviously even what the definition of intersex is, and if we see somebody who has Klinefelters or Turners or especially CAH, of course, we might not have any sort of difficulty coming up with the diagnosis of intersex, and we might sort of decide that somebody who has Klinefelters is testosterone deficient and be prepared to support that, or somebody with congenital adrenal hyperplasia, of course, is hopefully in the hands of a clever endocrinologist who's looking after that. But more recently, people with sort of structural issues and even hyperspadias has been labelled by some as an intersex condition. And I guess I think that most paediatricians wouldn't agree with that. But once again, assume nothing from the person in front of you. And I've had people who have had hyperspadias repair as a child come and tell me that this was, you know, contravening their rights and they should never have had surgery. And anyway, as I say, medically, we might not agree with that, but never assume anything and listen carefully and try and work out where this person is coming from. So once again, the person who comes in and says, well, I've come because I want hormones. What would I ask? Well, I'd want to know, obviously, the typical medical history, and specifically, I want to know if they're on any hormones. Antidepressants, people are often on antidepressants in sort of my experience, because they've often had quite a mental health sort of history, and they've often have diagnoses that range from autistic spectrum and ADHD and depression, and they've often had borderline personality labels and all sorts of things like this. and they've often been put on a whole lot of medicines that have not helped them, or maybe they have helped them. I want to know their immunisation history, and HPV vaccination, of course, is a very relevant one in this setting. And I just put that little comment with something I learned through ATAGI recently, of course, that the HPV immunisation, apart from being very useful in this age group, because HPV vaccination actually works, the average age that people now acquire HPV type 16, if they do, so the sort of strongest cancer-linked strain is rising. So we may actually change our target range for HPV vaccination, because it's no longer in late teenage or early 20s that you get your HPV 16 now, because it's kind of moving through the community slower. We may see people in their sort of 30s and 40s acquiring HPV type 16 for the first time. So vaccinating older people may become worthwhile. And I don't know when that'll change, because HPV vaccination is expensive. But
can I ask a question,
yes,
Nick, about HPV vaccination? Because
sure.
Now that the vaccines cover, say, 9 strains,
Yes,
or whatever, I sometimes see, older people who've maybe been married or in one relationship for some time, and they're coming out of that relationship and going into the world of dating, and their chances of getting exposed, to all those strains is there, and I'll often offer them HPV vaccination. But I wonder about the chances of you being exposed to all 9 strains when you become sexually active is surely quite small. So I just wonder why it's not, or should we be offering it more widely to people who didn't get it at a pre becoming sexually active age?
So my answer to that is absolutely yes, and I wish it was cheaper, and I wish that it would become licensed for this. I mean, it's a great vaccine. It's extremely effective, a very low failure rate, and already obviously, so the type 6 and 11 that were in the Gardasil 4 and still in the Gardasil 9 have seen young people with genital warts, the numbers, you just don't see them anymore. So it's been spectacularly effective, and even a single dose is very effective. And obviously we gave 3 of the Gardasil 4s, and we're giving 2 of the Gardasil 9s if people have them in the target age range of 11 to 15, where they're most efficient. The answer to your question, I think that I would refine it slightly, and I'd say that if people had had a negative cervical screening history all their life, so they'd never shown evidence of HPV 16 or 18 specifically, then if, as you say, they move from a sort of previous long-term relationship into potentially multiple relationships, then HPV vaccination is very logical. And, if they can afford it, and even a single dose, and I mean, that's off license to say that, but there's lots of evidence that a single dose gives long-term protection, and the multiple doses. So outside the 11 to 15 age group, they really need the 3 doses to get full cover. Within the 11 to 15, where people happen to be particularly responsive to vaccines like that, they can get away with 2 doses. But yes, no, I think the answer is if the person can afford it, then absolutely, that's a very good thing to do and highly logical. But we need, in a few years' time, and there's somebody on ATAGI who's an expert in this, who's particularly pushing for this, and I think the logic is great. We need to somehow expand the age group that people are covered for that vaccine.
Thanks, Nick.
Hepatitis B, I think, once again, it's a cancer-preventing vaccine. Hepatitis B is the world's largest cause of liver cancer. And when I put the 3 tests, it's just to remind people that to really screen people for hepatitis B, you need to do their surface antigen, their surface antibody, and their core antibody. And Medicare will cover that so long as you write query chronic hepatitis B on the request. If you just do a hepatitis B surface antigen, well, they're probably not carrying hepatitis B, but you don't know if they're immunized or not. I would order a basic hormone profile. It obviously depends which direction we're going here, but those tests are relevant anyway. Basically, testosterone production is largely autonomous, but to an extent, it's stimulated by luteinizing hormones. So an LH level is relevant. Remembering that, yes, once again, testes and ovaries both produce testosterone primarily, and then that's converted to estradiol by aromatase, and more so in assigned females at birth. But anyway, those hormones, I will always measure them. We always used to do the other hormones and prolactin and dihydroepiandrosterone, but they're not useful in terms of treatment decisions. This is a highly stressed population that comes in to visit, and the prolactin levels are always high the first time you do it anyway. So I have to say I've abandoned ordering those. We order carrier types. It's fine to order a carrier type on Medicare so long as there's any reason at all, and transgender is certainly a reason. And you do see variations, and every now and again somebody does come back with, for example, a Klinefelter, so I order those fairly often. Some of the regimes recommend that they are ordered in everybody who presents for possible hormone therapy the first time, but I don't order them always. Basic biochemistry, liver function tests, and electrolytes, obviously. Largely we're dealing with a young teenage and young adult population, so their diet may not be all that flash. So I'll usually order a few vitamin screens and things like that, but it depends. Lipid profile and glucose or an HbA1c, just because we're going on hormones and we need to sort of optimize risk factors. I probably should have included a thyroid function in that if a young adult population, although it's not specifically relevant to prescribing testosterone or estrogens. I always offer people STIs, and as I've said there, I mean, many people who are sort of on the gender spectrum will say that they're asexual and they've never been sexually active or not for a long time or whatever, but and then a proportion of patients are certainly sex workers and hopefully have regular STIs set up. But anyway, I'll always offer them, and generally people want to have those. And yes, don't forget the sort of other relevant swabs, other than including sort of pharyngeal and anal swabs for chlamydia and gonorrhea. And now this is just a recent British Medical Journal article, and Ada Chung is the lead author, so an endocrinologist in Heidelberg, who's very active in transgender medicine. So obviously people assigned at birth as male or female have different ranges for red cell indices and creatinine, and even liver function tests, AST and ALT levels are lower in birth assigned females. But when people transition, largely their normal ranges transition with them. And so Ada and friends here suggest that the laboratory should be putting both normal ranges on forms, and they have a point. So, I mean, for example, obviously a female hemoglobin range is lower than the male, and that's largely a testosterone effect, and testosterone is erythropoietic. It will stimulate red cell production. So males naturally have higher hemoglobin levels than females. And people who go on testosterone therapy will slowly increase their hemoglobin and can even end up with a secondary polycythemia. But the normal values in your mind as the treating practitioner need to be changed. And similarly, people who transition to an estrogen therapy will, over a couple of years, see their hemoglobins fall. And it's not because they're becoming anemic, it's because the normal values weren't changed on the form. So yes, a hemoglobin of 140 can become a hemoglobin of 115 when people go from testosterone dominant to estrogen dominant. And it's a normocytic sort of, they're not microcytic or anything like that. But people forget that, and people will, the patients are sent for all sorts of investigations for their anemia, but all that happened was that they stopped having testosterone. So liver function tests, so for example, alkaline phosphatase will often rise.
I did not know that. Thank you, Nick.
Well, that's okay. This is what this is for. But you know, I guess yes, think carefully about. So this article is wonderful. It's very recent. It's only a few weeks ago, and it's actually sort of open access, or I have a copy of it if people are having trouble accessing it. Alkaline phosphatase and aspartate transaminase will often rise when people go on testosterone, because they're increasing their muscle mass, and creatinine along with that. And of course, they go through all these sprains and strains when their increased muscle strength starts to take its toll, and suddenly the outphos is 160, and that's because it's not liver outphos, it's bone outphos. So anyway, just a sort of think globally when you see out of range results in front of you. Yes, fertility preservation I mentioned. if somebody is interested in semen preservation, then ideally they do that before they go on any estrogen therapy or testosterone blockade. And of course, they can go to Melbourne IVF, and that'll cost them a lot of money, but they can go to the Royal Children's Hospital Andrology. I included in all the files, I think I included the referral form there. The Royal Children's has an andrology department because of teenagers who go on cancer therapy and need to do semen preservation before they start their cancer therapy for their whatever unfortunate reason necessitated their chemotherapy. And they're quite open to outside referrals, and they really don't charge much. So you can refer people who are considering starting feminizing therapy. The testosterone blockers are quite likely to cause sperm generation to cease, and even when the blockade is subsequently stopped, if it happened to be, the sperm production doesn't always recover. Egg storage, of course, is far more problematic, and Melissa Cameron, that I think you all know, is a gynecologist with Melbourne IVF and is extremely sympathetic to the sort of transgender population, and will see people and will sort of organise egg harvesting and egg storage, but it's an expensive technology, and it obviously has not a very good success rate long term. So not many people opt to do that. There's a couple of other gynecologists who are happy to be involved, but Melissa is usually our first person. This is the Children's Hospital Andrology Department, and you see on the lower left or the mid left there, it mentions sperm banking, and if you click on that, you find a referral form. You just fill in the form, and they get a Medicare rebate for the semen analysis, and then they're charged a couple of $100s a year to store the specimen, and it can technically be stored for 20 years. After 10 years, the person receives a communication asking if they want it stored for another 10 years. Anyway, as I say, a proportion of people do opt to do this. They have to make 2 visits, and they have to be sort of about 2 weeks apart, but there's no waiting list. So just a reminder of a bit of biochemistry. I don't plan to go through this at all, but it's just to really make the point that all of these hormones we're talking about is based on a cholesterol molecule, and that progesterones and estrogens and testosterones and even aldosterone and cortisone, they're all related, and one gets exchanged to the other. And anyway, it was just to remind you of this thing that you learned a long time ago in physiology or biochemistry or something. So let's get down to the actual basics. We've seen the person, we've had a long discussion, we've talked about what hormones can and cannot achieve, and what other things they're going to do, and who's going to support them in this. I haven't gotten into the mental health side of things. Under the sort of informed consent model, people can undertake hormone therapy without mental health support. Obviously, we'd very much like them to have mental health support, and there's all sorts of reasons why that's appropriate, quite apart from the intercurrent mental health issues that the person may have, but I'm going to touch on that later on. But the people I asked all wanted to know about writing prescriptions. So estrogens, by and large, we will use estradiol. So it's a sort of natural estrogen, or what you call E2. So if I go back again, I don't know if I can, yes, I can show that. So estradiol, I'm down on the lower right here. So E1, E2, E3, but estrone and estriol are not really measurable, and we don't have easily available forms of those compounds to administer. Estradiol is cheap. It's easy to obtain, it's easy to take, and it shows up on the blood tests. Obviously, in contraceptive pills, we have ethinyl estradiol. Professor Zasach in Heidelberg likes to prescribe ethinyl estradiol. Nobody really understands why. Professor Zasach has been doing gender medicine for a long time, is extremely experienced, but ethinyl estradiol has a higher sort of blood clot risk, and you can't measure it on blood tests. And okay, anyway, so we tend not to use that. So optimal is transdermal implants, because that avoids the first pass liver effect. It avoids the derangement in sort of clotting profile and things like that that oral can cause. But it's much easier in most people to start with tablets and then sort of decide whether to change to patches and gel and things like that later. And many people do that. And some people who are very well researched and have read that it's safer to go on patches will ask for those right from the start. But the most common thing is to start with estradiol tablets. And yes, estradiol rather than ethanol estradiol. So Progenova, which is currently very hard to access because of a contamination that happened in the factory that makes Progenova, but Zumanon is almost the same. It's not exactly the same salt and the absorption characteristics are slightly different, but you can say near enough, it's interchangeable. So Zumanon 2 milligrams, we don't generally start with 1 milligram except in teenagers. 1 milligram doesn't really do much in this setting. And then 2 milligrams daily. So we're looking for, to feminize, you're looking for a estradiol level of at least around 300 picomoles per litre. So a male assigned at birth who does a hormone profile when they're not on any therapy at all, their normal estradiol could be up to 150. It's typically around the 70 to 100 range. And so we want to get their level up to 300 minimum. It could be higher than that, 400, 500, but to start to induce feminizing changes, that's what you would need. So you start with 2 milligram, and normally I write a prescription that says 2 milligram for a month, and then increase to 4 milligrams. And after another month, so at least 3 weeks, do a blood test and just see what level they have. Some people need 4 or 6 or 8 milligrams daily, and the occasional person 10. But if they're really needing 10 milligrams a day, that's a huge dose, and I'd really be pushing them to try a transdermal application instead. For people who are taking more than 4 milligrams a day, we definitely suggest they divided the doses up rather than take them all at once, because it's a bit unphysiologic to have this huge dose of estrogen at 8 o'clock in the morning, and then it's reaches a peak sort of 2 hours later and then starts to plummet. That doesn't quite look right. Testosterone blocker if desired, and it sort of depends what the pre-treatment testosterone was. So if the testosterone normal range is sort of 10 to 30 nanomoles per litre, then I sort of look at it and I say, well, if it's 30, you probably need a blocker, and if it's 20, you can probably wait and see, and if it's 10, you probably don't need one. But there's no urgency to start blockade. And you have to remember that if you give testosterone blockade, that tends to lower the testosterone much more rapidly than the estradiol can raise the estrogen level. So you can kind of, you've taken away their fairly anabolic mood enhancing hormone rapidly, and you've substituted another one much more slowly. So you can kind of leave people feeling quite depressed and sad and fatigued. So it's not always right to start the blocker right from the beginning. If you start with patches, then, I'm sure these patches are familiar to most of you, but a Climara 100 microgram patch weekly, or Estradot 100 microgram twice weekly. And in older people or people that I wanted to go a little bit more carefully, I might start with the 50 microgram equivalent of these. The 25 microgram doesn't seem to do much. There are such things as estrogen injections, either intramuscularly or subcutaneously. They're very difficult to use, and we don't recommend them. There used to be a product called Progen Depot that, well, I've certainly used years ago. I don't know if any of you are familiar. And that was a fairly useful depot estrogen that would last about 3 weeks. It's no longer available. The company that made it has ceased production, and nobody else has managed to make an equivalent. So the injections at best last about 4 days, but a couple of hours post-injection, the people have got a sky-high level of 3,000, and a few days later, they're kind of feeling fatigued and hormone deprived, so not recommended in most cases. So yes, start with estradiol, usually Zumanon 2 milligrams, blocker optional, and then 1 month later increase to 4, and then another month later, I would test their estrogen, looking for a level of above 300. I'd test their LH, and to suppress testosterone, they really need an LH below 2 and preferably below 1. And the testosterone level, it depends. So if it's suppressed to a sort of cis female level, that means it will be less than 2. Some sort of trickier questions that took place probably in the initial assessment is, for somebody assigned male at birth, how much male sexual activity do they wish to retain? People who don't feel that erections are supposed to be part of their life want a testosterone of less than 1. People who still wish to retain a degree of male sexual activity want to keep a testosterone level of at least about 4. And the kind of use of blockade also has to take these things into account. And there's a limit to how much we can tailor make regimes, obviously, but at least you can try. And okay, I just put some numbers at the bottom of that slide as the sort of targets that we have in mind. People do sort of sense their hormone levels, and the person whose level has got to 250 will say, I don't feel this is doing much. And the person whose level has got to 600 will say, I feel really good. I guess cis females, menstrual cycle starts with an estradiol of 50 or 100 at the beginning of the month and reaches a peak of somewhere between 800 to 1100 in the sort of mid-luteal phase. And I guess having 300 or 400 throughout the month equates to something like the same quantity of estrogen overall. I don't know how scientific that comment is, but I guess it looks a bit like that. Okay, so also you could start with some patches, as we said, and then the other thing that we do offer, well, I certainly offer, and we do through Equinox, and I've so far done one with Guada in Turn the Corner, is implants. So implants are usually 100 milligrams of estradiol, and there's 2 companies in New South Wales that compound them, so Stenlake Pharmacy in Bondi, or unfortunately Ballina Pharmacy, which is a wonderful compounding pharmacy in Ballina, but they're currently underwater. So I think we won't be using them for a little while. There is a gel, estrogel. I have very little experience with it. It's very new. It's obviously the estrogen equivalent of Testigel, which is very well established. Skin absorption of gel varies widely, and you really have to start with sort of 1 pump a day and wait for a while and then do a blood test and see what their levels are like and whether they need 2 or 3 or 4. I'm not super experienced with that yet, but it's definitely a question of starting the treatment and waiting for a while and then testing and seeing what happens. So that's Estrogel.
Can I ask a question?
Yes, please.
Just on that last slide, I've got a patient who's wanting to go on an implant. They
Yes.
were on one when they were in Sydney, and then they were going through the transgender clinic here, who pretty much said it's too difficult. But I was like, when I was looking it up online, but I was just wondering if you're compounding it through there, do they contact those pharmacies?
Right. So that's right. So what happens is it's actually in best practice. You can find 100 milligram estradiol implants. You don't even have to add it. But so how I do these, so I do them fairly regularly at Equinox. And as I say, we've done one so far in Turn the Corner. We called it an implanon. It's not an implanon, but it is insertion of a hormone implant. So basically, yes, you write a prescription. You have to print it. They can't accept the e-prescriptions for compounded medications at this point. So you print off. Now, you look at what their estrogen requirements have been. So the Sydney situation is there was an endocrinologist called Jonathan Hayes who kind of created gender medicine in Sydney. He charged a lot of money, but he was the only person doing it for a while. And he gave everybody 200 milligram. They don't make 200 milligrams. You'd have to implant 2 at once, which is quite possible, but it just costs more money. You write a prescription, you send it to either the Stenlake Pharmacy, which is in Bondi Junction. So you write the prescription and give it to the person, and they ring up the pharmacy, or you can go online and they email the printed prescription. And about a week or 2 later, the implant comes back nicely wrapped up in a sort of little plastic container, because they're very fragile. If you've inserted sort of the implants that were used post-menopause sort of thing, very similar. So you've really got to be careful with them because they're super fragile. And then they come along and see us. So you need a trocar, which we have some of. And
so we have some of those already? Because that was
yes,
my next.
We have some. I have some. Guada and Almira have some stashed upstairs. So yes, it's no problem to insert. It's a bit of local anaesthetic, and either into the sort of iliac fossa area or into the buttock, whichever they prefer. So it's an incision, and just insert the trocar and insert these and a couple of stitches or some steri-strips. And generally, the estradiol implants will last something in the order of 6 to 8 months. In older people, they'll often last longer. And the interesting thing about them is that they're not like patches or tablets where you get a sort of peak level a short time afterwards. As the implants start to break down, they have a sort of larger surface area, so the release of estrogen increases. So they often peak at about 3 or 4 months after you've inserted them, which is something it took me a little while to get used to. Yes, basically, anyway, Stenlake Pharmacy, I'd have to look up the address. I may have actually put it into best practice, I don't remember, but it's online anyway. But basically, if the patients had Dr. Hayes in Sydney before, which almost certainly they have, if that's what they're telling you, then they'll know where Stenlake is. So it's a question of, write the prescription and ask them if they know if they were having 100 or 200 milligrams. But if it was Dr. Hayes, they were probably getting 200. So they need to have, you literally have to write 2 on the prescription. And then, yes, we can insert it. And as I say, it's not a problem to do. It's quite easy.
Thank you. That's fantastic. Good to know.
So, okay. Well, and actually I also put this here because that's the, obviously that's off the Chemist Warehouse, and that's a lot cheaper than it was. This used to be expensive, so the price has obviously come down, so maybe it's being used. Now, progesterones. We actually use a lot of progesterones. So look, in trans men, the number one issue to remember is that testosterone is not a contraceptive in any shape or form. And even if people who go on to testosterone for gender transition cease to menstruate, they will still ovulate every now and again. And one of the reasons that in trans men, I include estrogen in the tests that I do, even though mainly I'm, of course, treating to get a certain testosterone level. But every now and again, you'll see an estradiol level of 1,000, and it's 1,000 because they've just ovulated. So conception happens even in people who have ceased having periods and have been on testosterone for a while. So the people who are trans men but still having vaginal sex need to have this sort of drummed in that contraception is necessary, and progesterones are very suitable. Progesterones do not they're not antagonists of testosterone. They are quite happy to live together. So I would use any form of progesterone-based contraception if that's indicated. First of all, to cease menstruation if that's a problem. And so Noriday is like as a progesterone-only pill, or Depo-Provera occasionally, although it's not the best choice because, of course, it can bring on acne and so can the testosterone. So probably less than ideal. But Implanon is fine, and we fix Implanon sometimes to sort of give long-term contraception plus menstrual control in people we have on testosterone, or a Mirena, and we use Mirenas, and it's better ideally, of course, that's inserted before testosterone is started, just because of the vaginal atrophy that the testosterone tends to induce. It's a much more challenging insertion, but just have in mind that progesterone is very suitable, and people who might need contraception do need contraception, and better to sort of face that early on. In trans women, progesterone, there's a lot of people who want it because they believe they will get breast growth enhancement. That's not sort of proven objectively. There's very little scientific evidence to support that. My own opinion is that I think there's a group of people for whom it works, but it's not predictable who they are. But progesterone is a pretty safe thing to do, and progesterone does reduce LH secretion, so it can act as a testosterone blocker in people if there's a difficulty doing that, or if the conventional blockers like spironolactone or cyproterone can't be used. And also, of course, remembering even spironolactone, it's actually a progesterone-based drug. It's an aldosterone antagonist, but once again, it's got the cholesterol-based structure. Cyproterone, which we use as an LH blocker, is also probably best regarded as a progestogen. The very occasional person wants to take progesterone 2 weeks out of the month to kind of induce a hormone cycle, and well, I can't see anything wrong with doing that, but it's a sort of rare request that some people have. And the choices of progesterone, obviously, if it's oral progesterone, Noriday, Provera is traditionally used, but it's not reliable as a contraceptive, and it's not very skin friendly, as we said. Micronized progesterone, so Prometrium, is expensive. It's $1 to $2 a day if they take 100 milligrams, but it's got a reputation as being kind of naturally metabolized and better absorbed. And I guess I think that a lot of people like prometrium. So yes, and clinical trials do not support use of progesterone, aside obviously from the contraceptive issue, or if it is being used as a testosterone release blocker.
I think Shamala had a question as well, which I wondered about as well, because obviously a lot of our talk we've been hearing at the moment is very much pushing not to use most types of progesterone because of the cancer risk. So I guess you're kind of saying it's not that big a deal, but lots of other talks we go to say it's a huge deal. So I don't know how those two fit.
The cancer issue here is, of course, complex, and I was sort of going to mention that a little bit later, just sort of cancer in general. So, well, I've certainly been in a situation where, for example, I have in Equinox one person who is a trans man in their 30s, has already had a personal history of breast cancer in the sort of late 20s prior to commencing transition, and had, well, obviously the oncologist concerned was brought in and said, well, there's just no information about using testosterone in people with a past history of female breast cancer, but no objection was raised. So that's and then we run into this also in people with previous ovarian cancers and so forth. The transgender literature is not too concerned. I guess I think that's the I don't know whether I believe that micronized progesterone has a lower cancer risk or not. I've seen some things that support that, but I mean, I don't have enough background or knowledge to really comment on that. It's well outside what I'm sort of knowledgeable about. But I mean, if you're sort of talking about in another setting, if you were talking about hormone replacement and postmenopausal situation and whether you use progesterone or not, is that the sort of situation you're talking about, or?
Yeah, I suppose we're kind of really being suggested that, you know, in that population, you really shouldn't be using anything but micronized progesterone or an IUD, you know, or an Implanon, sure, and big push away from all the other forms of progesterone. So, and mainly it's cancer risk. From my experience, I'm not sure about the VTE part, but I suppose, yeah, I suppose for trans women, is it because they have less breast tissue? That's not the issue, or?
For trans women, yes, that the answer is yes. Now, I'm going to show you another slide further down here. I mean, the Breast Screen Victoria has recently sort of put together a strategy for managing people who are transgender, and it takes obviously into account also their surgical history. So mammography is now offered to trans women if they have significant breast development. Nobody knows if that's important or not, but it's now available. So, and of course, it's not called breast screen, it's called chest screen in that situation. So CH, not PR. But I think it's, in this setting, I think it's unfortunately rather evidence light and very hard to make any recommendations. We would love to prescribe micronized progesterone to everyone, although of course, if we need a contraceptive, there's not evidence that that's adequate. So if we need a contraceptive, well, we are stuck with either Noriday or with the long-acting reversible contraceptives. But in the older age group, well, the issue for the Equinox population is price, and $1.50 a day is beyond what many people there could come up with. In the Northcote population, that may be, of course, a different situation.
I think the other thing is, I suppose, my real world experience of using things like Noriday is it makes a lot of people depressed. Like, yes. I find that progesterone really causes problems with mood. So if there's not much benefit, personally, I wouldn't be taking.
Yes. So as I say, it depends why people want it, and if it's a contraceptive or for menstrual control, then people will take it and they'll feel happy to do that. But yes, if it's being used, as I say, the other reason that people believe that they should have it is to get breast enhancement, and I think that the evidence doesn't support that, and most people abandoned it if that was the only reason they were taking it. So, anyway, I don't know. And Shamida, did you want to say anything, or was that?
No, that's great, Nick. Thank you.
Okay. Okay, and actually I should be reading my chat, which someone's put there, which I didn't see. Okay. Okay, what about Slinda? Yes, okay. I'm still waiting for the opportunity to prescribe Slinda, and I think it's also expensive, is it not? But I mean, Slinda presumably, so if it's the drospirenone, then it may not be totally clean in terms of blood clot risk. And I think that Slinda has sort of two non-hormone containing days, does it not? So for the person who is trying to remove their periods and they've nearly achieved it with testosterone, I guess pill-free interval doesn't make sense. If the person wants it as a contraceptive, well, then yes, why not Slinda, except I suspect it's expensive. And as I say, I've failed to so far prescribe Slinda to anyone, but maybe you've had more luck with that. Testosterone blockers. So we've done the hormone profile, they've come back, they're all keen to start. We've ticked every sort of box, and we've worked out that they're going to start on oral or maybe transdermal estrogen. We've decided to give a blocker. So cyproterone is really an LH blocker. I mean, it's a puberty blocker in a sense. It doesn't have so much effect on FSH, but it's a very potent drug. And in the United States, cyproterone is not licensed at all. It never has been. They think it's a liver toxin. If people attend a transgender clinic in Europe, they're likely to be offered cyproterone first line, but something to remember is that Europe has a 10 milligram dose that we don't. We only have a 50 milligram dose. But if we try to use cyproterone, then you really need minuscule doses, and 12.5 milligrams, which is to say a quarter of a tablet twice a week, or even once a week, can be enough to totally suppress LH and testosterone secretion, or in some people you need more than that. Yes, beware and literally warn people that falling testosterone can be quite symptomatic. Just a reminder that, of course, we do also see cyproterone in the combination pills, or the fourth generation pills, or however we now call Diane and Estelle and Brenda and all of those. Those pills, of course, are not available in the US either because of the cyproterone. Spiro is a more traditionally used testosterone blocker. So once again, Dr. Hayes in Sydney used to give everybody, if they were doing oral, he'd give them 8 milligrams of estradiol straight out and 200 milligrams of spironolactone. Nobody needs 200 milligrams of spironolactone. I start them on 25, and after a month or two, I might give them 50. And obviously, we're just aware that it could slightly lower their blood pressure. The diuretic effect of Spiro tends to wear off after a month or two in that sort of dose. Yes, officially the dose is up to 200 milligrams, but I have nobody on that sort of dose. You get blockade before then. Spironolactone is a slight gastric irritant sometimes, and every now and again people get a rash to it, and I think it's one of these drugs that can cause these sort of localized drug reactions that nobody realizes is a drug reaction. But anyway, it's widely used. As I said, yes, no blocker, and see what happens. The T will often fall anyway. And you don't want to push the testosterone level down too far if people do want to maintain some level of male sexual activity. Incidentally, in this setting, Viagra and the PG blockers work. There's no reason why they shouldn't. Obviously, they're not dependent on hormone levels. Now, then we get to prescribing testosterones, and how do we do that in the people that we decided to give testosterone. So technically speaking, androgens are, of course, controlled, and they require, I'm just getting rid of this text, correct? They require authority, and that's a kind of loose recommendation that came in following all these allegations about people using androgens in sport, which are probably well-based, but anyway. So people who identify as a different gender are allowed under the PBS to be defined as having androgen deficiency. And they are, if you have looked at the criteria for prescribing testosterone in general in the PBS, well, it's androgen deficiency with a pituitary or testicular condition, and their testicular condition, of course, is that they don't have testes. So one of the criteria requires that people have raised LH. Well, of course, this will be the opposite in this case, but so it's the criterion that says that people have androgen deficiency due to a testicular issue, which the testicular issue is, yes, absence of testes, but you don't have to specify that. So the medications that we tend to use, so Reandron is obviously we would say a 3-monthly injection, and beware of that because it's often a much greater than 3-month injection, and Reandron definitely accumulates, and people who start out on 3-monthly injections after a while may need 4 or 5 or even 2 injections a year, may maintain sort of cis male level of testosterone. So it does need to be monitored. Primatestin is no longer on the PBS. It's a private prescription. It went out of production for a while, but it's available now. It's relatively cheap, and 250 milligrams roughly every 3 weeks, or in some people every 4 or 5 weeks. It can be a gluteal injection. It can also be in the thigh. It's only a 1 ml injection and it's not that irritant. And the reason that some people like it is they can learn to self-inject, whereas Reandron, we would never recommend self-injection. That's definitely one to be done by somebody who's trained. Now, I mentioned there Androfort. So some of you will be familiar with Androfort. So this is a compounded thing from Mount Lawley Pharmaceuticals in Perth. And the 5%, so there's a 2%, but you'd have to use a lot of 2%. So it's a 5% preparation, and people applying 1 to 2 mils per day as a cream rubs into the skin. And that can give sort of, once again, testosterone levels up in the 15 to 20 range. And that is available on the PBS. And a very interesting thing that happened in August was that the TGA added a requirement that the cream has to be applied to the scrotum area, which is a very interesting sort of restriction to place. They did not apply that restriction to Testagel, only to Androfort. So being from Perth, I did contact Mount Lawley, who told me that they had no idea that the TGA was going to do that, and they're trying to have that removed because obviously cis females who become trans men have difficulty applying this to the scrotum area. It doesn't actually say apply to the scrotum, it says to the scrotum area, whatever that means. So we've tended to sort of just kind of say that lower abdomen would satisfy that restriction. Now I'm trying to make this computer go back to life, which it doesn't want to. There we go. So if you look online for Reandron, this is also, of course, the testosterone undecanoate capsules. Oral testosterone is not really recommended. It has a massive first pass effect, and it causes a lot of derangement of liver proteins and associated with a significantly increased blood clot risk. It's suitable maybe for somebody who needs short-term testosterone because they're transitioning from one treatment to another, or they're about to have surgery and they have to come off their testosterone for a little while or something like that. But I literally through Equinox have one person on these capsules. But the testosterone undecanoate 1 gram Reandron is by far the most commonly used testosterone for trans men. And then, so we move on to the next stage. The patient must have an established pituitary or testicular disorder. So as we said, that's absence of testes. And then treatment criteria must be treated by general pediatrician, specialist endocrinologist, urologist, or fellow of the Australian chapter of sexual health medicine. Now, the fine print here says that it can be in consultation with one of these specialists or have an appointment. So depending on how desperate you are to write this, and I think Imogen, you asked me about this a few months back, through Equinox, I have an arrangement with one of the sexual health physicians, and we have a written protocol that so long as I comply with that, well, that's taken as being in consultation. So I simply put that person's name, because it's not actually required that the patient ever has actually seen the relevant specialist. There just has to have been a communication. Here in Northcote, well, I have tended to write letters to the relevant specialist, or I've written a letter to the Austin Hospital or whatever, knowing full well that the patient will never go there, but it satisfies the criteria. So up to you what you sort of do about this or how to manage it. The alternative is to get the patient to see an endocrinologist or a sexual health physician once and get approval. Once approval's been granted, of course, the same name can go on any further prescription once the relevant specialist has indicated support for the prescription, then that name can continue to be placed on prescriptions sort of indefinitely. And then once again, if you're prescribing the specialist, the authority prescription through PRODA, it's the second criterion there, which is the androgen deficiency and testicular disorder. Beware if you are prescribing Androfort or Testigel, the same criteria are listed on PRODA, but they're in a different order. So it's not the second one with Androfort, it's about the fourth one down, and Testigel the same. So you've actually got to read what you write before you tick it. So Reandron, yes, I guess you've seen this 4 ml of castor oil dissolved testosterone, so quite an uncomfortable injection to give. Testacaps, as I mentioned, the oral form of Reandron, same drug, and very hard to manage. The one patient I have is on 40 milligrams twice a day, and they have reasonable levels on that, but I probably should be encouraging them to move to injections. Androfort, as I mentioned, and that clinical criteria down the bottom, treatment must be applied to the scrotum area. Testigel, so Testigel comes in sachets, which are very messy to use, or in a bottle with a, whatever you call the thing, a pump at the top. So the manufacturers of Testigel think that everybody needs 4 pumps, which is 50 milligrams per day, but nobody needs that much. I start people on 1 pump, which is 12.5 milligrams, and I keep them on that for a month or 2, and then I do a blood test and see what their testosterone level is, and your target is around the sort of 12 to 15 nanomoles per litre. That's adequate for masculinizing changes. So yes, that's the Testigel, as you can see, and I would always prescribe the dispenser, not the sachets. And then it's the instructions. It's a little bit sort of a story, I think, but it does make the point that if somebody applies Testigel to themselves and they've left it on their hands and then they touched somebody else, in theory, a bit of transdermal absorption could take place in the other person who may not have wanted to have their testosterone level augmented. So they do have to kind of just be a little bit careful. That's probably more relevant if there's children around. And then, yes, if I start someone on Reandron, then 13-week intervals. We don't worry about peak levels. We're sure just after the injection that the peak levels probably do go above 30, which is a bit sort of supra physiologic, but you can't have everything. And Reandron's pretty stable, and you'll get plateau levels, you know, in the sort of 25 to 20 range for a couple of months, and then it will start to dip. So you'd aim for a trough level of 12, by which I mean that's when you give the next injection. And as the level starts to rise, it's not a question of giving a smaller dose. You give the same dose, but you space the doses out more. And many people after some years of Reandron can literally have doses twice a year, and that'll maintain adequate levels. Testigel, as I said, start with 1 pump and test them after a couple of months. Primatestin, it's a little bit less stable, but as I say, the advantage of primatestin is people can self-inject. It's not on the PBS. You're writing a totally private script, and $35 for 3 doses through Chemist Warehouse, and 3 doses will probably cover them for several months. And the Androfort, 1 to 2 mils, so 50 milligrams or 100 milligrams per day. And Androfort's a cream. It's a lot less messy than the gel to apply. I was hoping that Ahmed would be on the call and could comment about this. Clearly a significant possible side effect of testosterone therapy is what Ahmed called pattern hair loss. So people know about that, and people with the sort of relevant family history, we would often offer them finasteride right from the start, and there's a big belief in the transgender treating community that it works. I don't normally get into minoxidil, and I presume that would also be a good thing to do. So we look at the family history. I specifically ask about it. And if the person is worried about preserving hair and sees that many of their older relatives have pattern hair loss, then we will suggest finasteride right from the beginning. It's a DHT blocker. It's not a testosterone blocker. So I think that DHT is linked to prostate enlargement and pattern hair loss, and I understand that it's got a lot to do with development of secondary sex characteristics in sort of puberty, but in adult life it doesn't do much else. But Ahmed's the expert there. Just a couple of sort of people that I use. A lot of people, you know, right from the beginning, you have to ask people what they want, and not everything that people want is necessarily requires hormones. People who want voice changes. La Trobe Department of Speech Therapy has been doing gender medicine for a long time, and I did include referral forms to there. People can self-refer to their speech pathology department and get voice gender change, so voice feminization and voice masculinization. They offer both, and you can refer to speech therapists obviously on care plans if you want, but the La Trobe University offers a service. It's paid for by the Monash Gender Clinic. Psychologists and psychiatrists, lots of psychologists and psychiatrists don't really want to touch transgender issues. I have a list which I did include, I think, of psychologists that I know who are kind of gender experienced and gender aware and gender appropriate. The list of psychiatrists is much shorter. Fintan Hart and Jacko Erasmus and Caroline Ward, and I have to say I don't know many others. The surgeons, in the case that people do want to have gender affirmation surgery, Andrew Ives is a plastic surgeon in Balaclava, and Cheng Lo is, well, also a plastic surgeon in Balaclava, and they kind of work in a loose partnership. Andrew's been around for longer. So they're both doing chest reconstruction surgery, which will be called top surgery. And Andrew does a kind of a neo-vagina creation and will do an orchidectomy, does not do anything remotely resembling a phalloplasty. Hans Goosen is actually from Holland and trained in the UK, but now largely works in Brisbane and has a wide range of surgeries that he performs. He's the only surgeon in Australia doing phalloplasty, as far as I know. I have never sent anybody for an operation like that. I have been to presentations by him. The surgery looks totally horrific, to not want to put too strong a word on it. Somebody needs to be very well prepared. So a patient who wants to have gender affirmation surgery, for chest reconstruction surgery, they require a referral from a doctor, and they require a mental health assessment, and that has to be written along the guidelines laid down by WPATH, which is the World Professional Association for Transgender Health, and the psychologists who are gender experienced know how to write such a recommendation, and so did the psychiatrists. So either of those mental health groups could provide that recommendation. For people who want genital surgery, they require a recommendation from 2 independent mental health practitioners, as well as a general doctor. So that's a lot more rigorous. Some people will come and ask about facial feminization surgery, and there's a couple of people who do that. My limited experience is that people are often very disappointed with the results, and it's quite horrific surgery with a lot of pain afterwards. But Paul Paddle in Richmond, and Stephen Clyde, I'm not quite sure where Stephen is.
I just ask what that is. Like, what's
Facial
feminizing facial surgery?
Yeah, facial feminization surgery. Well, I guess it's a little bit trying to reduce the prominence of the forehead. It can be sort of, they do modifications to the jaw somehow. I mean, I have to say, when it gets down to detail, I'm not so sure either. The other thing that's done is shaving of the cricoid cartilage, so to sort of remove the Adam's apple. And the other thing that the ENT surgeons do, they can, you know, with surgery, they can make a voice, they can tighten the lower extremities or the anterior extremities of the vocal cords and make the voice pitch higher. So that's done, but even they'll say that you should go and do the voice training first. But yes, facial feminization surgery is something that people talk about. It was kind of put on the map by the so-called facial team who come from Madrid and who publish a lot and who come to Melbourne every now and again and do a collection of operations. But yes, in terms of the details, no, I guess I don't know the answer to your question.
Seems a very binary way of viewing, like
I totally
appearance.
agree with that. Okay. There's a ear, nose and throat surgeon in Adelaide called Walter Flapper, and who's quite well known in the trans community and who does facial surgery as well. Obviously, Melissa, which I think we all know, is a gynecologist who's very sympathetic in this area. And there's lots of endocrinologists people could see, but the ones that we often use are Ada and Brendan Prostajak and Leo Rando. And, you know, you can send people there if you sort of feel that you'd rather prescribe testosterone once an endocrinologist has given you know, is confirmed that that's appropriate, then you could send for a one-off opinion. And those people are all happy to kind of operate on the informed consent, so they don't necessarily require a mental health assessment if that's appropriate. And of course, mental health assessment is often highly appropriate, but in the setting where somebody is quite resolved and it's clear that's the way they're going to go one way or another. So I always ask people about their mental health history and how open they are to seeing someone, and, you know, strongly recommend and say, well, you know, no matter how mentally together you are, transition is a big thing and involves a lot, and to have mental health support is a great idea. There's often a lot of intercurrent thing. People often have already seen psychologists, and then it's a question as to whether they've actually divulged to that person whether they're planning to gender transition, and they'll sometimes say, no, I don't want to discuss that with my psychologist, and then you might offer them a different one. So anyway, but I guess, yes, it's important to be offered. Just to mention this, so Gillick competence used to apply in this area with under 18, and it no longer does since 2 court cases in Sydney. So what they called Ray Kelvin and Ray Imogen, and Ray Imogen was only a couple of years ago. And basically, these were cases where people under 18 years of age sought to have gender therapy, and one or other parent objected and took basically took their child to court to try and have this blocked. And Ray Kelvin, which was a number of years ago, more or less said that Gillick competence did kind of apply, but it was assessed and reinterpreted under Ray Imogen, and the High Court judge who gave the determination from that case said that it was illegal for any kind of gender transition therapy to take place without the sort of more or less signed consent of both parents, and that even applied if one parent was estranged. So that's meant that even for places like the Royal Children's, who of course have a large clinic for people under 18 who are gender transitioning or seeking to gender transition, so where both parents will sign a consent, then it's legal for the person to undergo therapy. Now, you know, you can argue, what about a sort of teenage trans man who wishes to cease their period? So you put them on progesterone. Under the sort of interpretation of Ray Imogen, even that, if the primary objective was to treat period dysphoria or something that could be seen as a sort of gender-related thing, could be technically seen as illegal. Now, I don't think that that would succeed, but nevertheless, the Ray Imogen findings were quite restrictive, and needless to say, there's moves afoot to try and have that overturned. So Michelle Telfer, who is the head of adolescent medicine at the Royal Children's and head of the gender clinic, certainly has a lot to say on this and is quite active politically in this area. And what she says is that they also now will not commence therapy on anyone, and that would include puberty blockers, without the consent of both parents. And if they can't get that, they'll actually take a case, the 5th point here, Justice Connect, which is a service which I didn't know about before speaking to Michelle, but it's a sort of charity, a pro bono legal advice, and requires a doctor's referral. So I have never done this, but in the event that a sort of well-informed 16-year-old with one consenting and one dissenting parent wanted to advance their gender transition, and for some reason that was in my hands, which is not very likely because I don't tend to treat this age group, then I would be writing a letter to Justice Connect, and they would take on the case. And Michelle's experience is that every case she's presented to Justice Connect has been won. The judges always come down in favour of transition if a good case has been put forward, supported by medical evidence. So for people who are 11 or 12 and consider themselves transgender, or who are assessed as transgender and who manage to enter the Royal Children's, they will be put on puberty blockers if that's considered appropriate. So that's usually leuprorelin. And I mean, it could technically be cyproterone. It'll probably just about work as well, but it's a rather fierce drug to use. So not everybody agrees with that approach. And the problem with delaying puberty is that it has an uncertain long-term impact on bone maturation. And also, one of the technical arguments is that if you don't allow the secondary sex characters to develop well, then it may be a loss of tissue that could be used in later sort of genital reassignment surgery. So I'm not sure how much I agree with that, but it's something that's raised. But I guess I do worry about the bone maturation sort of issue. And my view is that it's a bit theoretical because I don't do this, but I imagine that if somebody has reached 13 or 14 and their hormone levels are already high, then to swap them to the other hormone is probably appropriate. But yes, Tanner staging, once somebody has reached Tanner stage 3, it's too late for puberty blockers. So if the LH is greater than 0.5, it's an easy way of doing it, then puberty blockers will no longer work. So you've really got to get in early. So Tanner 1, there's sort of no LH, and Tanner 2, there's 0.25. Yes, once you reach basically 0.5, then it's too late for anything other than sort of just support the person, do all the other things. Yes, get the speech therapy, see the mental health people, do whatever else you can do, and then decide at what point hormones should start. For other teenagers, if they don't want to be on the long waiting list for the Royal Children's, there's a couple of private endocrinologists. Jackie Hewitt is one. But if they have to buy the leuprorelin, I mean, it's more than $1,000 a month. It's super expensive. And well, anyway, I guess it's a possibility for some people. Yes, just to mention, this is a website in case you can't remember your Tanner stages. And looks like that. And you can't see the top of that because of the screen, but anyway. Just a couple of other things. I think a couple of you said you've already looked at some of these. So the WPATH, the second one there, this is the body that really writes the manual that everybody uses, and these are the people who write the guidelines for the mental health assessments. Australia has its version, the AusPath, and that's obviously I'm a member of that. It's quite a nice organisation. They hold an annual meeting, and it's a kind of a website where if people have questions, they put them on the listserv and other people answer. Facebook has a GPDU, General Practitioners Down Under, subgroup for gender affirming healthcare. It's a nice group. Once again, you can put questions on if you get an unexpected question from someone or you get a side effect you didn't expect. Transgender Victoria is a good group for counselling of relatives. So when somebody comes in and says my spouse or my child or my parent or somebody suddenly announced they're trans and what am I supposed to do and who can I talk to, Transgender is very good at kind of having resources for the connected people. Fenway is a very large clinic in Boston, great website, lots of information. A couple of the documents that I use came from there. ACON is based in New South Wales. It's once again, it's just a website with a lot of information. Equinox is obviously the Victorian AIDS Council clinic that's now in Abbotsford, used to be in Fitzroy. Panch was a great idea that sort of never got off the ground in Preston, which they did have a couple of doctors prescribing there, but they no longer have doctors. They have good peer navigating people, or some people with lived experience of being trans who will provide good counselling. So somebody who's looking for that could certainly get that from Panch, but there's no medical activities going on. So yes, that's the place in Preston. Now there's just, I should have shown you these earlier on, but there's just these two. So this comes from WPATH, and it's the sort of what happens if you take hormones. You've got copies of these in the files I sent out. So obviously this is somebody who goes on testosterone, but you can't see the top of the screen. And the list of things that are highly likely to happen and when might they start, obviously a wide range, and when might they reach the maximum effect. So I usually sit down with people and give them this and go through line by line and say, is this what you were expecting and how much does this worry you? I guess once again, there's probably not many surprises on that list, but it's a good talking point to get started. And then I would always remind people of these things, that if people go on testosterone and take it for a while and then stop, then the sort of body contour changes and the skin changes and so on will largely revert. They may take longer to revert than they took to change, but they will revert. But these list of 4 things here will not revert. Every now and again, you get someone who says, I just want facial hair and a deep voice. So they could probably take testosterone for 1 or 2 years and then cease, and they'd have what they wanted. But always good to remind people that these are the things that they will not be able to undo. And then, you know, the side effects other than the irreversible ones. Just to mention, so acne obviously can be treated. Acne is caused by testosterone in any situation, so treatment doesn't change, except of course that you can't use estrogens to treat the acne. But you can use the usual topical things. You can use doxycycline and you can use Roaccutane if it comes to that. Well, we can't, but somebody can. Irregular bleeding, as we mentioned, progesterone. A vaginal atrophy, it's probably not quite the right expression in this setting, but topical estrogens are fine and they're quite often needed. Testosterone is associated with endometriosis, and it took a little while for me to quite understand that, but you definitely get pelvic pain syndromes, and every now and again somebody actually has a laparoscopy and what they've got is widespread endometriosis, and it seems that the same thing happens with tamoxifen. So sort of paradoxically, estrogen is linked with endometriosis, and so is lack of estrogen. So I guess I don't totally understand the mechanism, but this is well recorded, and people who are on long-term testosterone who get pelvic pain need to have endometriosis considered as a diagnosis, and potentially have someone do a laparoscopy if it comes to that. And it's obviously there's not many treatments that can be offered given their hormone status other than laparoscopy and sort of surgical removal. Always remind people that testosterone is not a contraceptive. And then tendinopathies and enthesiopathies. So that's what you see when people have these new levels of testosterone and their muscles strengthen up and their bones are just the same, but their tendons and ligaments do not keep up with this. So they get sprains and strains and injuries, and they're quite common, and they get tendon ruptures and so on because the tendons are much slower to sort of catch up. Polycythemia, so you do have to watch that, and people who run testosterone levels too high can get very high secondary polycythemia, and to the point where they have to have venesection, or basically we often tell them to become blood donors, which obviously achieves the same thing. Every now and again you uncover an actual primary polycythemia through this from people who were anemic when they used to sort of have heavy menstruation and so on. But for the most part, testosterone induces polycythemia, and things like cholesterol obviously should be looked at. And then this is the equivalent list for people who go on feminizing treatment. The issue with decreased testicular volume, it depends a bit. It usually does happen. It doesn't mean that sperm production ceases. So it says underneath there decreased. People who go on cyproterone, these changes are more marked, and I've certainly seen people who, or I'm aware of cases where people came off their feminizing therapy, but testicular function never resumed. And it doesn't help to give testosterone. If anything, that suppresses testicular function more, in the same way that the athletes who take too much testosterone and they literally turn off their endogenous production, and it can take a long time to recover. So breast development that occurs with feminizing therapy, which that's not inevitable that will happen. But if it does happen, that doesn't reverse. And as we mentioned, testicular atrophy and the other side effects. Peyronie's disease occurs, well, that's probably secondary to sort of lack of erections, but people do get deformity of the penis, and they get to the point where erections, when they do occur, become painful. And nobody quite knows what to do about that. I mean, nobody knows what to do about Peyronie's disease either. So maybe that's just sort of the same situation. The occasional person wants to feminize, but without breast development, and that's, you know, often too hard to achieve. But there is such a thing with using the SERM, so the selective estrogen agents like raloxifene. It's not very feminizing. It is very bone protective, of course, because that's its role. But yeah, especially people who read the American sites, they'll come along and ask for that. And once again, the lower hemoglobin is not actually a side effect, it's normal. So yes, just remember about the normal ranges changing and the changing hemoglobin and hematocrits, liver and renal function, as we said. And yes, if creatinine and the AST rise, well, that's quite possibly to be expected. Cervical cancer screening ideally is done before commencement of testosterone therapy. Of course, if people are transitioning before age 25, that's not available. If self-taken screening comes in from age 25 in July, as was planned, that will be very much easier. Obviously, in the Equinox environment, self-taken screening is very popular. Mammography, if the person has developed as a trans woman palpable breast tissue, then mammography is now available when they reach the relevant age. So 45 or 50. If people have had chest reconstruction surgery, as in bilateral mastectomy, then it's up to the surgeon to determine whether there's any residual breast tissue or not. If not, then they probably don't need mammography, but I guess it's a pretty brave surgeon that says that they removed everything. Prostate cancer, in theory, on estrogen should be less likely, but there's actually no evidence over prostate cancer one way or another. So I guess I think that I do sort of think about prostate cancer at least, and take PSAs and ask people about symptoms, once again, if they're the relevant age. This is this thing from Breast Screen Victoria. It's just on their website now, and it talks about the different groups and who might benefit from screening. Yeah, the various surgeries that people might have, which I guess we've already mentioned. And that's Andrew, this gender surgeon down in Balaclava, a very nice person. This website is worth looking at. Underneath the tabs there, the transmasculine and transfeminine, there's quite a few of the surgeries listed. This is the other colleague from, it's less well known here, but it's basically an associate of Andrew. And this is the man in Queensland who does the sort of genital surgery. And next time when we want to take a bit more detail, the other things that we could talk about, I guess, chest feeding, as in a trans woman, can they breastfeed? It's happened. The people can achieve it. There's long-term progesterone and one of the galactagogues, so 60 milligrams of domperidone a day and a lot of nipple stimulation. It's been recorded. Yes, don't forget STI screening and PrEP and so on. The trans population, it's said that we don't offer it nearly enough. Binding is obviously what people do when they have not had mastectomy and they're trying to reduce the prominence of their breasts, and tucking is what the cis males use to make their genitalia sort of less apparent, with either clothing or tape or various things. And that's linked with lots of physical symptoms. Binding is a cause of quite significant chest pain, and people don't understand why, if they've been applying binding for 14 hours, that their chest cartilages are all sore. Okay, that's what I had to say. Now I've left you all stunned.
Thank you, Nick.
That was probably a bit long, sorry about that.
Thank you, it was fantastic.
Yeah, no, really, I learned a lot.
So all questions welcome, or send me emails or whatever. Yeah.
Thank you very much. It was really great. Can I just ask one question? On the previous slide, there was something about giving hormones temporarily to achieve non-binary status.
Yes.
So how does it work? I mean, is it so for cis males, you would give some estradiol for
Yes, that's right.
certain period of time, and
That's,
vice
so,
versa.
you know, I guess it's very important. The initial thing that I wrote there was ask the person what they're really looking for and sort of have a serious chat about how realistic that is. And a lot of people's aspirations are totally unrealistic and, you know, just not possible. And what it says on the internet and what we can actually provide are often quite different to each other. You know, the person who's looking to get a bit of breast enhancement, let's say they want to do, I mean, people come along and say, well, I was assigned a certain gender at birth and I just don't wish to be assigned as that gender. So I wish to be regarded as, you know, so I'm androgynous, or so it's not clear what I am. I just don't, you know. So, but the person could take estrogens for a while, maybe sort of probably ideally about 2 years, and get a bit of breast development. They could also, of course, take a blocker. I mean, let's face it, spironolactone, if you put people on spironolactone for a while, they get gynecomastia. Well, that's actually the same thing. It's called something different, but it's the same thing. So, you know, people can do things like that if that's what they want. So yes, certainly I always in the initial counselling talk about people may start and stop, because of course people can start and stop so long as they realise what they're doing. That's fine. And people come in and say, well, I've decided to have a rest for a while, and they think I'm going to yell at them. Well, I'm not going to yell at them. Obviously, we talk about what, you know, why they decided that, and circumstances outside, or, you know, they weren't being accepted in their sort of preferred gender in their community, or they'd reached the level that they want, or for whatever reason. But yes, certainly starting and stopping is more or less fine. You know, it's probably not ideal, but you know, for some people it may suit what they're looking for. But some people achieve non-binary status. So, you know, birth-assigned females who get a double mastectomy, or what would be termed top surgery, and, you know, and dress a little bit differently and cut their hair short, may achieve what they want. And they haven't been near any hormones, sort of thing. So yes, I guess I think that the initial question, and where it's not clear what the person wants, then yes, then they have to go away and think that through a lot more carefully. But a lot of people come along and they're very specific about what they want, and then it's a question of whether it's achievable.
Thank you.
That was great. Thanks, Nick.
Well, obviously you're welcome. Okay. Well, if that's it, then thank you. Sorry to keep you so.
Thank you.
No, it was really good.
Okay.
Thank you very much.
Thanks everyone
Thank
for
you.
Bye,
joining.
Nick. Thanks, everyone.
Thank you.
Nick. Good night.
Thanks, Nick.
Thank you.
Bye-bye.
Bye.